A quick note before we begin. This podcast dives into real, often raw conversations about life's most profound moments, from a labor's beginning to life's end and all the complexity in between. Some stories may be emotionally challenging or deeply moving. Please listen with care and know that you are not alone. Welcome to the Mamatoosa podcast. I'm your host, Atusa Benji. Welcome to the Mamatoosa podcast. I'm your host, Atusa Benji. Today, I have with me the lovely Dr. Daniel Niku.
Take lovely.
And you are lovely and kind and humble. And I'm just so honored that I got introduced to you. Dan and his beautiful wife, Tanya, just had a baby.
7 months old.
7 months old, baby girl. And they asked me to be their childbirth instructor. Mm-hmm. So I love that because you would think, why does an OB need a childbirth education class? But the reason is that in medical school, I haven't been to medical school, but I'm assuming that you're learning from a certain angle that doesn't involve yourself and the person who you love, who may or may not be carrying your baby, going through this process yourselves. Mm-hmm. So it's from a subjective angle. And I have to tell you, he showed up, he had a notebook and a pen.
I still have that notebook.
You still have the notes in there?
Right here.
And he took notes like, lovely, and asked questions, and his wife is amazing. And I'm so grateful that you had a beautiful journey and a healthy baby. And from there, we started thinking about, okay, I already knew that Dan is very respectful of the midwifery model. I'm a licensed midwife. I work with Naomi Drucker, who's a certified nurse midwife, and I also assist other midwives around town. And I've been in the Los Angeles birth world for almost 25 years now. It's kind of scary considering I'm only 30, but I started in preschool.
I'm 18, don't worry.
Essentially. So we have worked together. We've had mutual clients together. And what I always say is that the perfect scenario for a community birth or an out-of-hospital birth or a home birth or a birth center birth, whatever you want to call it, is when you have a collaborative physician who is aware of what your scope is, what you can and cannot do, is there to pick up the phone when you're like, hey, this is what's going on, we need to come in. And there is a plan of where you will meet and how you will meet and how the hospital staff receives you upon entering the hospital. To me, that is the gold standard of community birth. And yet we struggle because many doctors are unwilling to back up midwives. I know doctors who I respect and adore, and as soon as I'm like, hey, what do you think about I don't back. I love you. I respect you. I know you do good work. I don't back up midwives. Why?
I think it goes in the same direction as how, we feel as MDs about midwifery practice and as midwives feel about MD practice. I think there's I'll be very honest, when I was in training in residency, we had a midwife on staff, and, we learned from her, but she was at the tail end of her career. So it was kind of like a perusal. It wasn't really something that we got too involved with. So we were always taught what people like to call a medical model. We were taught about labor, but the perspective of midwifery has created some disillusionment. Mm-hmm. And I think that comes from bad experiences. And I think the recent rise in desire for home births, or the desire to be in a community focused or holistic, however you want to interpret it from a midwifery perspective, if you call it that, is people want to have less medical intervention. So that's where the danger starts to come in about we are living in our biases. So when I left residency, I had my hesitations because all I associated midwifery was home birth and the dangers of home birth. And we can talk about that another time. But when Naomi from LA Midwives had approached me as to be a backup, I did it initially as to be honest, to be available to make some extra money on the side kind of thing. Yeah. Let's be honest.
You were a younger
doctor, trying to establish my foot. And a lot of people are like, are you crazy? And some nurses said that, some residents said that, some MD said that. And I go, okay, it scared me. But as time goes on, these are patients and these are practitioners that desire an ability to give a new perspective or an old perspective in a new environment.
Right.
What got tricky is finding ways to be communicative. And I think that's where we have a lot of pitfalls, is where we don't communicate openly about what patient options are. So I think the gold standard can be practicing safely midwifery style things in a hospital setting, so you have that backup. Now, if you choose not to do that, don't do that. I think a lot of problems that we've run into, and the reason a lot of MDs are hesitant about midwives, is because there are some midwives, not all, there are some midwives that have done some borderline mavericky things that scares a lot of patients and doctors, and likewise the other directions. Like, this doctor did this. Well, I've heard a midwife who's done XYZ.
Right.
And I would have that hesitation also.
Right.
Okay. So
right.
I think with all of that information of like disillusionment and bias and stuff like that, it's time to kind of take a step back and look forward to say, okay, I've met Mamatoosa, I've met Naomi, I've met this midwife. And it's like, what works best for me, what I'm comfortable with, and be a little bit okay with kicking down a door and say, okay, I'm okay with doing this, and being a little bit more, what's safe to push the boundaries, because I think we've gotten too comfortable. There are certain things that we're like, oh my God, I'm going to get sued and I'm going to be freaking out.
I have to do it this way.
And I have to do it this way.
Yeah.
So there's a lot of fear. There's a lot of disillusionment. It's time to like change that. And I think for myself personally, and I feel like I'm rambling, but it's gotten to a point where we need to start changing that mindset a little bit.
Tell me a little bit about your practice.
It's in Beverly Hills. I deliver at Cedars. I used to do a lot more deliveries for a Medi-Cal clinic also. That was earlier in my career. I'm now 7 years into practice. Wow, 7 years. You say 25, I say 7. It's I'm actually 25 years old. I started at 18.
Very young.
And I did a lot of things by the book, when you're starting out, things that they don't teach us in med school or in residency, or, a lot of midwifery stuff, but also how to run a practice. So the first few years has been a lot of like growing pains. But once your name gets out there and you see the patients that are looking for you as much as you're looking for them. And so my style of practice has been try to be as communicative as possible. My patients, get my phone number. There is, a lot of practices that administer a concierge or administrative fee, and I do the same thing. And I deliver like 10 patients a month. But I try to be as involved as possible with the mindset of what a lot of my colleagues like yourself have advised in like midwifery practice. Let them labor at home. Let them check their temperatures. Let them, if they break their water, why do they need to run in? Why do I need to start Pitocin? Let things kind of kick off themselves.
Right.
And I clearly remember from, Atusa said that, that birthing class was for me and my wife. Really, it ended up being a lot of it for me, because I learned a lot also. Like, it's a lot of nuances. And the best example, because we're talking about Pitocin, or I mentioned it, is that you said it's like a very fine-tuned machine, and you start disrupting it a little bit, whether that's self-stimulation or if it's with, Pitocin that we administer intravenously. You may disrupt a natural cascade that happens. So you have to be very cognizant about that. So if my patients can get into labor on their own, great, let it happen. If nothing happens and you're at the hospital and you're sitting around for 8 hours and you've made no change, then let us help you. We're not forcing the issue. We just want to provide a little bit of a kickstart. And maybe you don't need as much as we assume or hear that people are getting all the time. So I try to be hands-on and hands-off. It's a fine balance. I'm still learning every day.
For sure.
And how to do that.
For sure. And there's clear cultural differences, because I know that for midwives like myself who also doula, so there is a model of care, which we've talked a lot about on the podcast and on my Instagram, called being a monitrice, which means that you have a license to be a midwife, but you are able to be a doula, but also provide checking vitals, taking the, making sure the client is doing well during labor, checking the cervix, checking progress, making sure that mother and baby are essentially doing okay before you go to the hospital. So when I talk to fellow midwives, many of them are like, how do you even do that? I refuse to do a monitrice, because when I go to the hospital, it is so difficult for me to watch the protocols that are imposed on people that I know don't have to be there, that I don't even do at home. So why do you do this model? I can tell you that the way I wrap my head around it, and I also speak to other midwives, more experienced than I and younger than I, where I will tell them, treat it as if it's a cultural difference. You're going on a field trip. Mm-hmm. You are going to see something done a different way. Mm-hmm. For example, I like to think I'm pretty good in the kitchen. I make really good Persian food. I make bomb rice, right? I make really good quality long grain basmati rice with fresh saffron from Iran. My oil is perfect. My pans are perfect. I will give you a bomb tahdig, right? But that doesn't mean there's only one way to make rice. Correct. If I'm going to someone else's kitchen, I have to now be like, okay, at the end of the day, we're going to get a delicious bowl of rice. But I can't go there and be like, hey, no, you need saffron, not
right.
Why are you your temperature? I have to understand that I'm going into a different area that is actually not where I usually practice, and be open to that while my client knows that I'm actually really good at Persian rice and I know my way around a kitchen. Yeah. So it's a very interesting place to navigate. Mm-hmm. And it's not until doctors and nurses walk in who even have known me forever, and they're like, hey, it's so great to see you. And we have this just great bond. And it's so lovely for clients to see their doula or their midwife bonding with staff, because then everyone's nervous system is just chill. But at the end of the birth, where they're like, it was so nice working with you. Yeah. Almost this like, I had to prove myself that I actually know my shit before there's any sort of acceptance. Yeah. Because many times, especially if I wear I try not to wear a midwife shirt at all when I'm doula monitricing. Once in a while I will, because it's just when I grab in the middle of the night. When I'm monitricing, I usually just wear a doula t-shirt, because it creates a lot less like, she's a midwife? I don't really even know what that means. What has she done to this client before we got here? Has she given her something? Have they done something? I think there's an innate distrust that has been created because of the history and politics of birth in this country, which we all know what it is. But it's not until midwives have to outshine before many doctors will even say hello to us. And so I think part of the most powerful work that I do is as a doula monitrice, because I know how to make really good rice in the kitchen, so clients hire me because they're like, well, you know what temperature, and you know how to work the kitchen, you know how to work the stove, and you know that you can use the oven or the stove. They hire me for that. And I think some of the most powerful work we do is the education at bedside, where clients can actually be like, can you all explain that to me a little better?
Why did you, it feels like you're taking an extra step in understanding the environment of the hospital. Yeah. I think it happened organically. Okay. I think because I was a childbirth educator first, that was the first thing I did. So I really got into understanding physiology and understanding the terms. And because I was always so curious and almost like a nurse midwife on the inside, I asked a million questions. I was the doula who at the end of the birth, I'd be like, hey, doc, can I ask you a question? When you did that suture backwards, why did you do it like that? And they'd be like, why are you asking? But I was fascinated by it. I'm still fascinated by it. So I did a lot of self-study, I think, number one. And then I was a doula for a million years before I became a midwife. So I understand hospital culture very, very well. Mm-hmm. Very well. So I know that poor nurse who walks in the room and is handed a 7-page birth plan with some woman wearing, a t-shirt who's been home for 2 days with the client laboring, and the whole situation doesn't really make sense. And the nurse is like, what is happening here? Yeah. Then a resident walks in, and then the doctor walks in, and then the charge walks in, and everyone's got to guard their liability. Yeah. It creates distrust in the room. So one of the jobs I love best is being the doula monitrice, because I'm almost like the party planner. I can help you have a really good experience because I've worked at that hotel before. I've worked at that hotel when the catering didn't show up, when the roof fell down because it was raining, so there's something to that. One of my clients said it's like climbing Mount Kilimanjaro with a guide. Mm.
The guide will tell you, come on this side, it's shady, or pee here, or stay away from that leaf, or we don't need to do that right now, we'll do that later, or eat right now, because right now is the time to eat on Mount Kilimanjaro. That's why I do it. But to go back, many of my colleagues are like, it's too hard, it's too tolling to be in a culture where you sometimes know that what they're telling your client is completely untrue.
Can you give an example?
Example. Client comes in, knee deep in labor. All of our phones are on because we're all chronically on call.
I'm on call for myself, my partner, and Dr. Ruffet also, and I'm on call for the emergency room this coming weekend. So yeah, I have the
good times.
Yeah, good times. Sorry,
good times. It's going to be super quiet. Yeah. Nothing's going to ring. It's going to be fine. Example. Client does not want a hep lock.
Hep lock, by the way, is where you don't put the IV connected. You actually put. You can choose to put the IV in and like close it, or not put anything at all. If you don't want an IV at all, rather than connecting an IV, you just put something.
It's just a portal. It's just the catheter goes in, gets taped, and you never see it again. But they suck. They're uncomfortable. They're pokey. You're in labor. They suck. So is it or is it not true that you have to have a hep lock, and that if you don't, it's hospital procedure and the doctor cannot go on doing their job if you don't get one?
So you're asking the wrong person.
Okay.
I think it is part of the standard ordering procedure.
Right.
And the reason is as such. Number one, for instance, if a patient wants an epidural, you need an IV line placed. And that's to this. And the reason is because some anesthesiologists like to give a fluid bolus, to give a certain amount of fluid in order to keep the vasculature of the patient up, because God forbid something happens during the epidural. So that's standard. So, okay, so that's
fair enough. Okay, yeah. But
God forbid there's an emergency. We don't have to, during an emergency, place, a hep lock, for instance. We don't have to put an IV in. So they think, okay, let's preemptively put one and have it in place. Oh, we're going to start Pitocin. We need this already in place. Why are we delaying? So I can see why it would be part of it.
Absolutely, I can too.
But I try for my patients to convince them, listen, if you don't want the IV fluids, if you don't want that, you can choose not to put the IV in, or at least have the IV in and just close off the valve so that you don't need to get the IV. At least we have the access rather than waiting for an emergency to happen and struggling and something like that, which is rare, but I think that's more precautionary. So to answer your question, I think it is part of protocol, but you can choose to not have it. And I think that's a good way of going about it.
I think that's where midwives struggle. And I don't want to speak for every midwife in the world, but I talk to a lot of midwives. And I think a lot of times when we see pressure put on patients or clients to do things a certain way, where we're really like, does it really have to be done that way? I mean, the truth is we could talk for hours. There's so many things to talk about. Why is it that doctors don't make eye contact with us?
With who? Midwives?
Mm-hmm. Or doulas?
Generalizing here, because I can safely assume, because most of the practitioners that are at Cedars, for instance, use the midwives that are on staff.
Right.
And not the residents. So
right.
I think when it comes to outside midwives, I think there's like this perception that you guys are mavericky, granola-y, like, you're gonna, and there are some, and they will push the boundaries of what's medically, like, what we know is right, compared to what you're like, yeah, we tried this tincture. And I'm like, what the fuck is a tincture? Like, why are we even bringing that into the conversation? I think there's a little bit of elitism. I think there's a little bit of like snootiness about it.
Yeah.
But the same can be said. I would turn the question back at you. Why do some midwives and doulas look at doctors with such disdain? Why do they have like an animosity and this like, I'm going to like challenge you on every single thing you do, to even to a point where it's like, yo, chill out. Like you are not the client. It's like there are vendettas. There are personal, goals here. There is snooty attitudes on both sides. I think it's not just like why doctors, but I think it goes a little bit both ways. A little bit. Why do some midwives feel that it's okay to push the medically safe boundaries beyond what is medically safe? As an example, I had one experience where a patient came to me and they were brought to me at 43 weeks and change. And it is recommended, not only by us, but I know by midwives, to not go beyond 42 weeks because of XYZ risks. And we can talk about the risks in another time. Mm-hmm. Why is that challenge? And I know patients want to have a unmedicated, minimally intervention, experience for the labor process. Why do we do it? Why is it done unsafely that way? Why do they push it that way?
Obviously, I can't speak for every midwife on the planet, and nor do I really know many midwives that would go to 43 and change. Although I think that the 42-week mark is a guideline that was created by ACOG and the College of Obstetrics and all of those minds that came together to create protocols. We know that some women just go to 43 or go to 43 and a half, and they go there safely and they go there genetically. Like my mom went to 43, my grandmother went to 43, not mine, but we know that that runs in their family line. Also, if that client is being monitored, if there are NSTs and BPPs that are happening, we know that the amniotic fluid index is good. We know that the baby is a normal size. We know that possibly her last pregnancy went over like that. Mm-hmm. I think that midwives create for a little bit of a common sensical, and again, in my protocols, I can't go past 42 weeks because California law states that at 41 and 6, I need to transfer to a collaborating physician. So at 41 and 5, I would be calling my collaborating doc and being like, hey, like, this is where we're going.
So that's where my problem is.
Which is?
I have experienced where they have not collaborated until it's gone beyond that.
Because some doctors, and again, I think that when the collaborative relationship is made, you all don't even know what we do. You don't know, not you, but in medical school, there is such a disdain of go to a midwife, or, oh, she's going to a midwife. Or I even heard that, when the future Queen of England, what's her name? Princess Kate was having her baby, one of the doctors made a snarky comment like, oh, she's going to have a home birth. We'll see how that goes. Right? Why? Why do we have that? So before you answer it, I think that there has to be some understanding in your medical schools that teaches you what licensed midwives do in your state. If you are at UCLA Medical School or USC or wherever else y'all may go, that says, did you know that there are a group of people called licensed midwives? Did you know that they are trained and licensed by the medical board who licenses you? So if this is such a crappy board and they're just they're just boarding idiots, then they're boarding you too. So clearly they've seen some safety and some research in what we do and been like, okay, well, if we stay within parameters of no high risk deliveries, no insulin dependent diabetes, no twins in this state, no breaches, don't go past 41 and 6, collaborate with a doctor if something is slightly off, blood pressures. I mean, I've called you before and been like, hey, look at these test results. What do you think? So long as the doctor knows what my scope is, and I can understand that this doc is, I don't want to say doing a favor, but going against the grain of your medical school fellows to do what you're doing, then that's what's going to be successful. Mm-hmm. So the art has to be in, hey, Dr. Niku, will you be my backup? Yeah. How do you practice? Well, I actually take people who don't do anatomy scans. That may not work for you. You may be like, I don't want to back you up if your client hasn't had an anatomy scan. I need to know, where's the placenta? What's going on with the heart? What are we doing here? Yeah. So there's ways that we can finesse it and ways that we can collaborate without this fear of, I don't back up midwives. And when I challenge that doctor and say hey, do you know that we carry meds? Oh yeah? What do you carry? Methergin, Cytotec, TXA. Did you know we can give IVs? You can give intravenous medication? Yeah, we're all skilled and trained in doing that. I had no idea. You can manage a hemorrhage at home? Yeah, we can. You can resuscitate a baby? Yeah, we can. So you don't know, not you, but most doctors don't know. So they hear midwife and they think it's some cat carrying crystal person on a broomstick that's going to show up at the door and be like, take my tincture, I put you into labor, which sometimes we do that too. But typically, and our tinctures work. because it's not only the medications that have been FDA approved are the ones that work. They're only the ones that have been researched.
I'm not disagreeing with that.
Right?
Yeah.
So that's the thing, is that if I am going to be working with you and I tell you, hey, doc, when my client has preterm labor contractions and I want to calm that uterus down, this is what I use. Right? Okay. And you're going like, wow, what is she like? Skull cap and lobelia and valerian root. Like, how fascinating. Okay, tell me how you're using it. Like this. How about if I use this and I keep in touch with you and with the client and see what's going on with her contractions, and she calms down, and then you see like, whoa.
So here's the tricky part.
That protocol worked.
You're not wrong in saying that these are opportunities or, avenues to consider. The thing and I'm being very frank and open about it, the thing that terrifies us the most, and I'm speaking generally, is like, what the hell happens if it doesn't? And guess who, if a lawsuit happens, and again, this comes from now a place of fear. And it's not just medical system. It's like, it's funny when you ask people socially, wow, you're an OBGYN. It must be so fulfilling. So like, you guys don't know what the fuck we go through.
Oh, for sure.
I love my job. I love what I do. I'm really good. I think I'm really good at what I do. But there's an innate fear that when I have a $60,000 a year, which means $5,000 a month malpractice to cover my ass,
yeah.
And that ass, when it takes on the responsibility of backing up midwives, and then there are some irresponsible, and I'm not saying you,
nope.
I'm generalizing,
yep.
When there are some irresponsible choices made, or choices where let's try this that's not quote unquote FDA approved, and something by happenstance goes wrong, guess who it falls on? Well, the midwife may be the one that made the choices. They're going to ask the patient, they're going to ask the midwife, who is your backing up physician? And guess who the buck stops with? It's us. And I'm the one that gets called in to sit on the stand and say, why did you allow this to happen? Kind of thing. And maybe that's not always the case, but I think that's the innate fear. And that's probably why there's such a fear for doctors taking on that quote unquote liability of backing up a midwife. I think the end result needs to be just being open and communicative and finding a collaboration between an MD and a midwife or doula and the team. It takes a village, and you have to be a little bit open. You have to be a little bit, I'm going to push the boundaries, and there has to be openness on both sides to really make it work. And
client-centeredness. People have a choice about where they want to have their babies.
Yeah.
And people have been having babies outside of hospitals since the beginning of time.
Yeah.
And it usually works. One of my favorite things now to say to myself is that I feel like the hospital system is so proud that they are able to manage emergencies so well because the OR is down the hall. But I think that same hospital system is creating the high-risk scenario to begin with, and then fixing their own problem. Would you agree that many times when low-risk pregnancies are left alone, not alone in meaning like no care, but when the body is left to do what it's designed to do, it does pretty well?
I think so. And that could be done, by the way, at home or in a hospital setting.
Absolutely. Either way. Absolutely either way. Do you think that the average person who goes to medical school knows the difference between a doula and a midwife?
I don't think 99% of the people know the difference in general.
But what about in medical school where we're in the same field?
I think there might be a little bit of a change happening, but I think it goes with the cultural perspective, and it takes one MD or one midwife who works in a hospital system to really change the perspective. I can't comment. I can say I didn't know much about, I know what midwives were. I mean, I'm Jewish, and, we talk about in the Passover story about midwives. So that's
we do. Yeah.
But we don't talk about it a lot in med school, and, I was exposed to it in residency, but I think, there could be a better effort to understand and maybe even integrate it in residency programs to make it, I know Cedars does.
Amen.
They spend at least a month, I think, the residents with the midwives to understand. Yeah. Is that enough? No, it could be more. I think. And
the midwifery model that Cedars has is not the midwifery model that we practice out of the hospital.
Not always.
Your midwives are typically physician extenders. They are not primary care providers. So a true midwifery model is when you ideally meet your midwife early in pregnancy. You establish care. That same midwife has continuity with you every month, every week, every 2 weeks, whatever it is, catches your baby and then has 6 weeks of postpartum care with you. That's the midwifery model, not come in and break the water because the doctor's not here, or come in to teach the resident. In some hospitals, the midwife is the lowest on the totem pole. She doesn't even get to catch a baby because the doctor does it, and then below that, the resident does it. And if no one else is available, she'll catch the baby, or they'll catch the baby. It's not true midwifery. If you were to spend a month coming to home births or to community births with us and seeing what it's like to labor for a day and a half in someone's living room, and the cleanup and what we schlep and refrigerating medications and making sure we have everything and the way that midwives collaborate with each other, you'd be blown away by how beautifully the model works when it's done with respect and communication. I think respect, trust, and communication are the foundation of any relationship, whether it's a marriage or, right?
She made sure of that.
Right? Yeah. So even more so when we have lives in our hands.
Yeah.
That's just where it has to be.
Interesting thing that came out on the American Journal of Obstetrics, AJOG, Journal of Obstetrics and Gynecology. They did, I think it was a meta-analysis. So basically they took all these studies that they had done from different countries. So not a
randomized control study.
Because it's very difficult to do randomized studies in pregnancy.
For sure.
But the idea was to see what the primary outcomes in terms of like tearing, APGAR scores, time of delivery and whatnot. Like, I think there were a lot of factors. I briefly read the summary, and there were a lot of positive aspects of a water birth, and there's a lot of confusion and disdain. When I was in med school, I was at a small community hospital, and they had water tubs in each of the rooms. Nice. Was it used? Not always, but it was available. Listen, water births are physically a challenging experience because you are. When I push with a patient, I want to give them every opportunity, especially if they're with an epidural, to push in different directions. So that's one physical obstacle. But then now you're talking about getting in a pool and
getting wet
and doing all these things, and you're being present with the patient, and people are like, that's disgusting. The amniotic fluid is coming out, meconium. I've been pooped on, sprayed on, peed on, bloodied on, and everything. So
amniotic fluid in your shoe. Did you get that one?
I'm sure of it.
Yeah.
I'm sure
that's a good one.
The best is when I have speckled blood on my glasses.
On your glasses, yeah.
And my patients look at me when I go back to the office after delivery, like, what the hell happened?
What happened over there? Yeah.
But that being said, like, it's important to understand that if there is an opportunity, and what makes me proud of that article is that it's coming from a major obstetrical, gynecological perspective, that people are fearful of the medical system. We are talking about this shit all the time, people. It's not like medical doctors are out to get you.
Right.
We're here to we are investigating options. I think there's now going to be that trend in that direction. For
the doctors who are willing, and there are doctors who are completely unwilling, just will not go there. It's just like a territory that I will not touch. And so maybe doctors of your generation, maybe doctors of this area, I don't know. But all I know is that there are so many family physicians who are so open to midwifery care and collaboration. And for years, family physicians did births. And in many states in the United States, family physicians do it. But when we get to obstetrics, you all are skilled in high risk delivery, in situations that are out of the norm.
I want to disagree with you in a little bit, in the sense that I think we're skilled in all facets. What makes us important or available is for the high risk stuff.
Correct.
I want people to understand that I think we do it. Especially for myself, I try to do a damn good job for my low risk deliveries. I just want to let people know that maybe as MDs, maybe we can focus on other things as well, or make ourselves available for when a low risk becomes high risk for, we need more practitioners. We need more midwives and, MDs to do the birthing process, but it's hard. I just don't want to put in people's minds that we don't want to handle low risk stuff. We want to, but I don't know if you're...
I'm arguing that you shouldn't need to.
I agree, but I think we should. I argue that we should do more in the sense that we should make birth fascinating, and I think we've made it more a rote thing that it's just like, oh, you're pregnant, okay, this is low birth, and which probably to your argument is, oh, well, if you're dealing with the rote easy stuff that's just like kind of like your day-to-day, give it to you guys to do, which is great. I think we should do that, but the problem is we live in a system, and whether that's in this country or whether that's availability and training of having individuals like yourself who are qualified and making good midwifery medical judgments are very hard to come by, I think.
I think that finding physicians who are truly client-centered and process-oriented versus results-oriented are very hard to come by.
Yeah, that's hard.
It's being more hands-off and letting the process happen, listening to the client when she says, hey, like, this doesn't feel right in my body, or let's do it this way, or no, doc, I'm feeling strongly about this. I think that if more physicians did that client-centered care, there would be less lawsuits. And that's the other problem. So when the average medical, when the appointment is 7 minutes, how are you going to do that?
Let me ask you this. Forget about time in the office. You are very client-centered. You're taking care of your patients, but would you want to take on 10, 11, 12 low-risk deliveries a month? Be honest.
It's unmanageable. We can only do it in a group.
So now take that where I'm a solo practitioner and I'm doing, let's say 90% of my patients, even with like some diabetes or a little bit of high blood pressure, are all manageable. So I'm doing 10 deliveries a month, 10, 12 deliveries a month. It's manageable. I try to have a client-centered, as you know, like approach.
Yeah.
But the problem is when you're coming and telling me, I don't want to take 10 deliveries a month. Like, what are we supposed to do? Who are we supposed to train? Because to be honest, while there are great doulas out there are some really shitty doulas out there. While there's some great MDs out there, there's some really shitty MDs out there. While there's some great midwives, there's some shitty midwives. And the problem is it comes from training, it comes from perspective, it comes from attitude, it comes from so many things. The question really has to be answered is, how do we make a good training opportunity, or how do we collaborate amongst people that requires them to understand what low risk and high risk pregnancies are and how to practice it effectively while making good practitioners available, not shitty ones.
And so there has to be a model where, like in many countries in Europe, for example, my brother lives in Amsterdam. 50% of women are still having babies at home there. 50%. Now, interestingly, in the United States, midwifery was sort of taken out of the hands of women and midwives, and then women fought for it, hand and claw, and got it back. But it was like, okay, well, you can be a midwife, but you got to be a nurse midwife, because a nurse midwife works under the doctor, and we still want the doctor to be the head honcho, right? In many European countries, if you are a nurse, it actually counts against you when you apply to midwifery school. They want you to go into midwifery without the medical model information. So when you become a nurse or a doctor or any practitioner who is practicing in a system which is governed by med law, then you're always like fall risk, sue risk, this risk, that risk. And a lot of times when all you do is think about risk and being sued, you cannot practice in a client-centered way. The person who was here a few people before you, she said something like, this doctor was managing a shoulder dystocia, and he said, I saw my life pass before my eyes.
The doctor said that?
The doctor said that. Yeah. And she was like, he saw his career pass before his eyes, or he saw his life. She was like, I'm so confused because it seemed so doctor-centered when the client and the baby could have died.
So I will tell you, like, for someone who has experienced shoulder dystocias.
Oh, yeah. I had one yesterday.
I didn't see my career.
Yesterday.
Yeah. I didn't just see my career. I saw, gotta get this baby out, gotta get this baby out.
Yeah. Oh, yeah. There's just nothing that's like your heart rate's at 210.
Terrifying thing.
It is awful.
Awful.
It is awful. And do you know the number one, when they did research on shoulder dystocia, what was the number one confounder of shoulder dystocia that increased the risk of shoulder dystocia? Was an epidural.
Interesting. And why is that?
Many reasons, because in my opinion, when a person is on an epidural, I don't think the baby does the rotations as effectively because the mom is not moving in a way that is going to bring the baby down, that is instinctive and intuitive.
I'd like to see that side. I'm curious about that.
Yeah, I can show that to you. The other thing is that when you have a shoulder dystocia at home, and I had a guest last week or 2 weeks ago, God bless her, we had a 10-minute shoulder dystocia at home. And by the grace of God, mom and baby are healthy. We did about 8 maneuvers over and over again with a mom that was healthy and strong. We were like, lunge, get up, turn around, McRoberts, turn around, Gaskin, turn around. We did so many maneuvers with her, and she was able to follow, and she was able to move, and she was agile, and she was like, I'm on it. Let's get my baby out. And we finally got the baby out, on the bed, pulled the legs forward all the way up. Finally got a contraction and the baby came out. It was terrifying. I mean, talk about literally, you want the world to stop.
Did you see your career?
And you want to die.
Did you see your career flash before your eyes?
I didn't see my career flash before my eyes. What I saw was, first, you're not even thinking about anything else but get this baby out. And then the resus that comes afterwards. So what you all have that we don't have is that part of your coming in at the last part of the delivery, which for you come a little sooner. You actually push with your clients. I had a birth last week where the woman pushed for 5 hours. The doctor literally came when she was crowning. The client called the doctor and said, Doc, can you please come? I've been pushing for hours. Can you just please come? She said, no, love, the nurses will manage your pushing until I get there. I don't come until the head is showing. But that baby came out. That was just shoulder dystocia. She was there to manage the shoulder dystocia. It wasn't my delivery. It was the doctor's delivery. A very hard labor, big baby. But she was like, I don't come until the baby is there. But in our model, we are the midwife. We are checking heart tones. So we are the external fetal monitor, right? We are the IV team. We are the resuscitation team. We are the postpartum and the baby nurses. We are all of it. You all come and you sort of have a team that you delegate to. When you get that baby and you put that baby on the mom, you don't even worry about the baby anymore. When I catch a baby and I put the baby on the mom, now I'm looking for bleeding and my partner is checking baby, because you know that when mom hemorrhages, baby usually doesn't do great with transitioning either. Or when you have a shoulder, the baby doesn't come around so fast. So we always have a team of 2 or 3. So it's a wild phenomenon that all I can sometimes do is like interview and get on my soapbox and cry and shout and yell and journal and talk to fellows. And I'm like, but where's the change? What are we going to do, Dr. Niku? We're still young. We're in our 20s. We can make this happen.
And I have my ideas. I'm working on my ideas. That'll come one day, hopefully.
Okay. Next podcast.
Next podcast. The reality is, I think, there needs to be a change. I think there has to be an open perspective. And I can't be the one that only does it all, but I can hopefully be a cog in the wheel. What's important to me, and I tell my patients, especially the midwife patients that come to me for backup, the buck stops with me, but you trust your midwife. You let them do what they do best because you trust them. My job is to learn from them, but to be there when you need me most. But my job is also for my own patients, to really understand how to provide low risk interventions that are low risk, meaning like, hey, try these maneuvers at home. Hey, there's a great website called Spinning Babies. Try these maneuvers that I can show you to do too. Hey, when you're in the hospital, we can do this. Hey, you want to have a birthing ball? Great, we have a birthing ball. Hey, do I have to push on my back? No, you don't have to push on your back. Let's push like this. Do most patients do? Yeah, but we have alternatives. Hey, do I need apoptosis? No, but when the time, what's really important for me is to take, and I try to tout myself this way, is taking a lot of philosophies that you guys advise, learn from it, see if it applies, if it doesn't. And I hope that midwives do the same thing from our perspective, meaning like, hey, maybe the doctor is onto something because there is some dramatic things that could happen. Am I prepared for it? Am I ready for it?
1,000,000%. I mean, some of my favorite moments are when I'm in the hospital with a client and the doctor will either go back and forth with me about, hey, what do you think we should do? And what do you think's going on? Which you and I did, which was amazing. And the client got so much out of it. She was like, I felt like it was one team working together. It wasn't like my midwife and my doctor. It was a team, right? But when a doctor was like, hey, Toos, come and look at this. Look at this cord. This is what it means. This is what you do with it. Look at this stitch. Look at this tear. Look at this blood pressure. This is what I'm thinking. And I'm like, wow, I'm going to take that and I'm going to take it into my home birth practice, right? What if you all came with us every once in a while and you did a few births with us, or you spent a few clinic days with us and you saw what we did? You saw that our visits are an hour long, and we sat down and we spent 3 minutes on listening to her baby, taking her vitals and maybe weighing her, but we spent 45 minutes on her broken relationship and her mom who just passed away, or her work status, or her immigration status, or whatever is going on in her life that is actually possibly causing the hypertension, and giving her tools so that can come down before she becomes high risk. Yeah. That's really what has to happen in my ideal fantasy world. We are almost out of time. I know that you're on call and your phone is blowing up here and there.
And I have a child at home also.
And you have a baby at home and a wife who's waiting for you. It's almost dinner time. Thank you for your time.
Of course.
I really look forward to seeing you again, having you on the podcast, and also collaborating on some educational stuff.
Sounds good.
Dr. Daniel Niku. Look him up, NIKU, and he practices at Cedars. It's an honor to have you on.
Yeah.
Thanks. Thanks for listening to the Mamatoosa podcast on the Industry Plant Podcast Network. Mamatoosa is hosted by me, Atusa Benji, and produced by Josh Stretton Carlson. Our theme music is composed by Mary Lalazarian. If you enjoyed the podcast, please consider leaving us a review and subscribing. See you next Tuesday.